Yeah. Didn't know you did my job.
Oh, wait, go.
Don't tell anybody. That's hilarious. Oh, dude,
Derek's got a second job.
dude, send it to me.
So just yell at me if I'm doing something wrong. Wait, Laura, when do we do that? When do we do it with the call to order roll call? Okay.
I'm glad this is on. He doesn't really know that as a full truth.
Yeah. I don't even know what the hell you're talking about. Listen, I just had an ear.
Did you?
I did. They were gonna go, remove the, phone and then put a titanium one in. This was Friday. And, went in and he went to go break the bone and it popped back into place. So he wakes me up from surgery, goes, hey, can you throw it up my mouth? You know, I go, you popping my ear? He goes, no. I go, yeah, I can hear you. So now this ear feels totally plugged. They're really. I'm about to wear my hearing.
Well, there we go.
My ear adjust, but it's making weird noises. Oh, yeah. It's like sticks.
Okay, guys, let's start trying to pull it to order just because we have a very big agenda.
I'm like,
I did. Nobody heard it.
a lot of stuff to do.
There we go.
Is your mic on, Dr. Carl?
I don't know. I don't hear the screeching, so it might not be.
Sorry.
Visualize it.
That's awesome.
Okay, okay, there's something. Anyways, I'm sort of loud and obnoxious anyway, so it'll work. Okay, so I would like to call this meeting of the Drug Device and Protocol Committee to order. We will now have our roll call. There's the screeching.
Chief Fulbright. Dr. Holtz,
Present.
Troy Biro. Mike Whitehead. Dr. Burnham,
Here.
James Whitworth. John Osborne,
John's in the.
Sam Scheller. Chief Moore. Dr. Leduc. Derek Cox.
Here.
Dr. Morgan. Here. Jim McAllister. Katie DeBash Manager. Here. Dr. Davidson. Brandon Miles. Chief Thornton.
Here.
Dr. Jensen. Chief Neal. Chief Lansing.
Here.
Dr. Dumontier.
Present.
Sydney Senecal. Dr. Barnum, you have quorum.
Okay, great. That takes us into first public comment.
Good morning, everyone. My name is Ryan Tyler, Ryantyler. Really quick, I just wanted to request that these meetings be monthly and or an hour and a half each. You have 9 things on the agenda, and it's not probable that you're going to get through all of them. So I would just request that these meetings be more frequent and longer to be able to get through them. The system is growing, our departments are growing, and to be able to do that, the meetings need to be more frequent and longer. Thank you.
Any additional public comment? Any online?
Nothing online.
Okay, great. Let's go ahead and move into the adoption of the, wait a minute, no, that should be adoption of the minutes. Don't we have to approve the minutes as part of the consent agenda? Okay, great. So let's I'm sorry, you said adopt the agenda and approve the minutes. Great. So is there a motion to approve for the consent agenda with the approval of the last minutes?
Agenda first.
Oh, I'm sorry. Yes. So is there a motion to adopt the agenda?
I'll make the motion. Yep.
Great. All in favor, say aye.
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 Great. That passes. Okay. And moving on to the consent agenda. Is there a motion to approve the minutes from the previous meeting?
Motion to approve.
Second.
All in favor?
Aye.
Okay, great. So we have minutes now as well. Terrific. So I want to move into the action items, and I'm going to be reshuffling these a little bit because it's going to be a long meeting, and I want to try to get some of the things that might be a little bit less controversial out of the way. So we'll go ahead and go into the discussion of potential formatting changes for the protocols. Laura.
Okay, so this came from the last DDP where we actually expanded the PEDS behavioral emergency protocol, and we realized that we're kind of running out of room and protocols are morphing into 3 pages long, and there's a lot of stuff that is on the protocols that is actually educational in nature and it's repetitive. And so in the efforts to make the protocol a better format for providers, we're trying to take some of the education out of there because they should already have the education in place before they get to us. So we're talking about going to the page 2 of the pearls of the back of the protocol and taking out the history box, the signs and symptoms box, and the differentials box off of each protocol.
Discussion. Does anyone?
I do recall when we first went to this new format from the old format, that was the idea behind it, was that it was very limited information on the protocol in terms of education. And it was very streamlined. And I agree. I mean, it's become very kind of cumbersome to sift through. I remember the initial discussion was keeping it 2 pages, 1 page with the protocol front, backside was the pearls, and it's kind of become this, like you said, 3 page, but that was never the intention when we went to this new format.
The counterpoint that I would make is that, I don't think many people are having a printed copy of the protocol manual at this point. There's really no reason for us to restrict it to 2 pages. And if it makes it easier to read and, less cluttered to expand onto 3 pages per protocol if needed, I think that's reasonable. Most people are going to be looking this up on a device, right, where you can look at it as a PDF file. It's searchable. And, although I guess I was initially, wanting to bring this up last time, after speaking to several paramedics who said they actually liked having that data in there as a reference, I think probably the best thing would be to leave it in at this point, would be my suggestion. But again, allowing the protocols to go on to 3 pages if needed.
I agree with that, Ben.
So that's interesting. You picked something that's less controversial, but it's controversial.
Yeah, I kind of knew that was how this was
I
gonna
would
go.
Maybe. I mean, even previous discussions in the education committee, it sounds like QA/QI committee is going to be refocusing, and maybe there's some realignment and stuff. And I would also add that you should also have QI metrics. Almost every protocol should have QI metrics, which may add to it too. So I see the point, though, that the providers do look at some of the differentials at times, not during the call, but after the call. So maybe it's time, and I'm going to throw it out there. This might be another controversial thing, but maybe we should be separating protocols versus education versus maybe a different educational manual that kind of just reiterates this and makes reference to the specific protocols.
Like it is now.
Yeah, like it is now, exactly.
If, you end up with twice as many, but 2 separate books. They're definitely not using it at the time.
Right, but it's still good. It's still a good
It's
reference.
great information.
And that's how the protocol manual should be used, right? So I would say let's not take any action on this at this point and leave it as it is.
Okay. I mean, I'm fine with that. Are we going to bring it back as a separate discussion of allowing an overall expansion of the protocols? How how is this? Are we done with this, or is
I
it
don't-
coming back in some form?
I don't think we need to, I mean, there's no rule that restricts the protocols to 2 pages. That's just kind of been by habit, I guess. So I think there's no reason for us not to just say, let's expand to 3 pages where needed. Because again, like, yeah, the thing that Dr. Young has up on the screen right now could easily be made more readable and easy to use if it were expanded to 3 pages. And there are several other protocols where that's the case.
Okay,
Can I?
yes, go ahead.
Okay, can I maybe make a suggestion? I think that there's a very significant difference between a protocol and reference material associated with a protocol that is not the actual like treatment algorithm or actual protocol itself. Does it make sense to say page 1 is the protocol and it's hyperlinked to the reference material relative to that, which is the pearls, which is any other additional education, but that the protocol and the QI metrics are really the things that providers are held most accountable for, and that should be the single page. And then everything else is kind of like in a reference section where they can look for further information.
I would say no, because then you're going to have to shunt the QI metrics onto the first page, which is going to further clutter the first page. They are all, you know, all of these things are in the protocol manual. They all have the force of a protocol, whether it's in the pearls or not. And again, I don't see a huge reason to change this at this point.
Are
Okay.
we testing? Let's rephrase. When we do SNHD testing for protocols and licensures, are we actually testing what's in the pearls and the signs and symptoms boxes?
We test on the pearls. We don't test on the signs,
Okay.
symptoms, or history.
So the question would be then, for licensing purposes, the information that is within the protocol should be the testable information and everything else could be considered elsewhere? Is that how we're doing it in the protocol? I'm just trying to clarify for providers that the information listed in the protocol section is the most relevant for testing materials, the history signs, you know what I mean?
Right, the protocol, the first page of the protocol, and then the pearl section.
And the pearl section. Okay.
So,
And when they ask, we tell them that every time. It's material.
Just for my own clarification.
so since the kind of the discussion that was the genesis for this has now changed, and we're now sensing that Dr. Holt suggested withdrawing that suggestion for the change, I think we should go ahead and then abandon this at this point. But it sounds like what we're going to then have coming back is going to be a discussion of, do we want to create like an educational appendix versus are we going to go ahead and expand the real estate for the protocols in the future? That kind of sounds like where we're at.
Do you want this shifted to education committee?
So that's a great question, and that had been my original intent when this was being framed as an educational issue. I think I think it would be a great question for the educational committee of how educationally valuable is this section of the protocols. I think but we're now into another question, which is, do we need to create an appendix for things, or do we need to just start expanding the protocols? And I think that's going to bear a little bit more discussion, because I know I've heard a lot of opinions on that. So since, like I said, we have a very full agenda, it sounds like there's not a lot of interest in passing that as is at present. Why don't we leave it as is?
Can I make a suggestion just to send a brief survey monkey of 3 questions to providers and let's get some feedback from the floor in general?
Or
Does anybody
can-
think that's useful?
I mean, I would be fine with that, but I don't know that we have the logistical ability to do that easily. I think we can send everybody from the committee back to their agencies and say,
Sorry.
okay,
That
yes.
is what I was looking for, is can the agencies go back, send a 3-question survey monkey, come back with the results so that we have kind of the provider usage?
Yeah, I mean, I'm fine
opinions
with
on the
that.
floor? I'm happy
Okay.
to do that.
So terrific. So we'll go ahead and table that and then move on. And going into the discussion of droperidol as a mandatory medication, Dr. Holtz.
Thank you. Yeah, so this just came out of it all being added to the pediatric behavioral protocol after discussion with our pediatric colleagues, Dr. Horning and others. They are of the opinion that droperidol is, the best medication for sedation in pediatric patients. I personally, and I know multiple of my colleagues believe it is a very good drug for sedation in adult patients as well, and it is already in our adult behavioral protocol. The only difference is that it's not a required medication to carry currently. So this would be the only change that I would be suggesting is to remove the two little stars on the formulary to make it a mandatory medication to carry.
Discussion?
Of the agencies that carry droperidol, do we have any idea of how often it's used and what the typical cost is?
I believe the only one that carries it now is CCT, from my understanding.
That's correct.
Right.
CCT.
So I don't think you're going to get much information on how often it'll be used. I think it will be used more frequently as people get more comfortable with it. The cost, I don't remember offhand.
Cost, that's, I was
Yeah.
curious if anybody knew.
I don't have the cost. off the
It's an
top of
old
my head.
it's an
carried
old
it
medication.
and we used it in December about 180 times. So we used it very frequently for nausea vomiting. We used it for sedation. 20% of the time was for sedation and most of it was for nausea vomiting.
I've got cost information. So on Life Assist, a box of 25 is $695. So that puts it at $27.80 per vial, give or take on your contracted pricing.
Additional discussion? I mean, I support the use of droperidol. I think that it has gotten a bad rap over the years, and it's effective when in the situations that we have it. And now that we're having all the hyperemesis problems, it's becoming more of a thing. We're actually having to get it back into the ERs as well. Okay, so as there's no additional discussion at this time, Mike, do you want to make that motion?
Yep. I'll make a motion to amend the not the formulary, I'm sorry, the paramedic medication list to make droperidol a mandatory, not an optional medication.
Is there a second? Okay. All in favor, say aye. Aye. Any opposed on this one? Okay, hearing no opposition, that motion passes. For the discussion of the OB uncomplicated childbirth labor protocol, my intention was to ask that we table this. I know that there's been some heartburn about this on the hospital side, and I know that some folks who represent the hospitals would like to come and speak on it. And so I was going to try to have them back in April. Okay, so we're going to table that for the moment. Moving on to discussion of use of amiodarone and lidocaine in protocol and formulary.
Good morning. This is a talking point from the last meeting that we had, and I don't want to jam up our whole meeting with discussion on this, but the hope is to add or to use in lieu of, depending on what this committee deems is the most appropriate thing, but to look at the use of lidocaine in replacement of amiodarone during cardiac arrest for ventricular fibrillation and VTAC codes. So in Henderson, the information that we gathered, the outcomes are very similar for lidocaine and amiodarone. That's why AHA has not taken a stance on which one is better, but they have said that they have very equal outcomes. I think there are smaller looks that have said that lidocaine is better. And I think that the thing that this committee should consider when choosing this drug or not choosing it is that the formulation of the amiodarone that we all carry for the most part has a dangerous additive, the polysorbate 80, which is usually related to hypotension, bradycardia, and low cardiac output. And they believe that in some of these studies, that's why when codes are shockable, the amiodarone is causing a hypotensive state, which makes it harder for all the other drugs to work, makes it harder for other therapies to respond to it. And then also post cardiac arrest ROS care is harder because we have loaded them with sometimes 450 of this. And that polysorbate 80 has a long half-life, just like the amiodarone itself. Amiodarone is also highly lipophilic, so there is a little bit of discussion on is the IO absorption reliable. Lidocaine doesn't carry these risks. It was used as a good antiarrhythmic and has a very high success of terminating ventricular arrhythmias. It is also hemodynamically stable. So there are enough studies that we have gathered in this proposal that have said that it's quicker to terminate the ventricular arrhythmia, but it's also more likely to result in a good ROSC outcome. And it has some natures of being neurologically protective. It is also significantly cheaper than amiodarone. So rolling it out, it would have the same recommendations as AHA. It would be cheaper for the entities to implement it. It would just be a thing of dosing and training them for what doses would be required. But I also think that the information that is coming out of this, and as we get more information, I think that lidocaine is going to be the superior antiarrhythmic. And our proposal today is to add it as a adjunct or a option for shockable cardiac arrest, right? Or to completely just say that this committee says that lidocaine is the antiarrhythmic that we use.
Okay, well, let me, so there's two issues there. So let me ask, is there thoughts on abandoning amiodarone completely? Is anyone else very much in favor of no longer using amiodarone in those pathways?
I would say no. I mean, look, I hope that we all agree that, you know, the majority of the evidence is that our treatment in cardiac arrest, you know, the most effective things that we do are good chest compressions and defibrillation when appropriate. The vast majority of the medications have not been shown to, you know, increase patient-centered outcomes. That being said, you know, the antiarrhythmics are still in the guidelines. I did a pretty deep dive into this the last couple of weeks, looking at, you know, AHA guidelines, the ERC, the European Resuscitation Council, as well as the, I think it's called ANZAC, Australia, New Zealand Resuscitation Council. I'm sorry, I'm probably getting the name wrong. But I'm sorry, ANZCOR, Committee on Resuscitation. All of them, you know, say, yes, you can use either amiodarone or lidocaine. There is no good data that, you know, shows that one is better than the other. I understand that amiodarone has been on shortage recently. I think that if we would like to go that way, we can add lidocaine as an option for cardiac arrest only. Lidocaine is not a recommended antiarrhythmic for VTAC with a pulse in any of these guidelines, either AHA or ERC. So, you know, again, I think that if we wanted to add this to the cardiac arrest protocol only as an option, as an alternative to amiodarone, that's fine. But again, I think we should have the understanding that none of these guidelines, you know, say that one is better than the other, or that, you know, to be honest, the antiarrhythmics have a great effect on patient-centered outcomes.
Okay, does anyone else wish to speak in favor of removing amiodarone? Okay, so does anyone else want to add into the idea of adding lidocaine beyond what Dr. Holtz has already said? So I can say that I think I'm in favor of the addition of lidocaine because it has sort of had a reemergence. I mean, you know, we all remember it from way back in the day, but it does seem to be reemerging based on its efficacy and safety profile. So I think that would be a very reasonable thing for us to look at. Does anybody else have any additional discussion on the addition of lidocaine as an alternate medication on these protocols?
I agree with the addition as an alternate. I fully support the addition of an alternate, certainly in cardiac arrest. I think I personally would like to take a little bit more time on the tachycardia side of the house, just to look, because I can see some stuff from 2017, but I'm not aware if there's anything more up to date than that, just based on some open evidence. But I certainly have zero issues with the cardiac arrest, and I personally would just like to take a little more time on the tachycardia side. But I don't have any strong feelings against it by any stretch of the imagination.
Okay. Does anyone else have any thoughts on the difference between on use in cardiac arrest versus use in tachydysrhythmias?
So from the most recent 2025 AHA guidelines, for VTAC or for wide complex tachycardias with a pulse, they say lidocaine's kinetic properties are less effective for VTAC at tolerated rates than amiodarone, procainamide, or sotalol, and it is unclear if lidocaine is more efficacious than placebo. So I would say that we should not add this to our tachydysrhythmia protocols. It should only go into cardiac arrest where it is in the current guidelines.
I knew we were going to wind up hearing about Procaine again.
Hey,
It's coming
procainamide would be an option.
No, I know. Okay, so it sounds like there's a broad consensus at this point to adopt it as an alternate in cardiac arrest. Okay, do we want to try to make that as a proposal that we adopt it in the cardiac arrest protocol? And then we'll hold off on adding it to the tachydysrhythmia protocol at the moment. Okay, so if you want to make that proposal.
So just a comment real quick,
Okay.
sir, please. The dosing for it for cardiac arrest. So, our medical director is in favor of using this. Just the application of it. If during a cardiac arrest, someone has a 90-kilo patient and we're giving 1.5, and then a repeat dose for refractory is 0.75. Could this get a little complicated on seeing what happened to 1 milligram per kilogram and then halving that?
These were just the ones that came out of the AHA guidelines. I didn't make these ones up. These just came from the most recent flow chart from AHA.
Okay. So my suggestion, Mr. Chairman, is to have it at 1 and then half it. If it's just a range, because we're dealing with cardiac arrest pre-hospital and
The range was 1 to 1.5 for the first dose and 0.5 to 0.75. And so I think the concern was just for easy math.
Yeah.
In 1 and then 0.5, or I'm even like, I could even do, I'm not opposed to 1.5 and then 0.5. So you're on the lower end of the second, but higher end of the first for kind of maximal.
No.
Okay. So I would even say 1.5 for the first,
Practicality.
1.5 for the first dose, 0.5 for the second dose,
So 1.5 for the first dose, and then you're,
just 0.5 per kilo for the
Okay.
second dose.
and I'm so sorry, to his point, would it not be easier just to say 1.5 and then just the 0.75 is half of whatever that dose is to make it easier math? Because yeah, if we're saying,
Whatever the first dose was,
yeah,
by
so
so I can see
yeah,
that
to
too.
make it to the point, it's like, if we choose 1, then it's half of whatever that is. If we choose 1.5, then it's just half of whatever that is. And I believe Dr. Leduc was in favor of the 1, or you can do the 1.5. Again, I think that there are enough cheat sheets and, resources for us to be successful no matter what. Nowadays, like, none of this stuff has to be by memory. We all use resources to make us successful, hand heavy, all versions of it. So I think that,
That's fine.
so 1.5 and then 7.4.
Leave it as written. That's
Perfect.
fine.
Okay. Okay, so do you want to go ahead and make that proposal?
Yep. So I propose to add lidocaine 1.5 mg per kg and then a half dose for the second dose. In addition as an option to the cardiac arrest protocol.
Just to clarify, you meant 1 milligram, right? Not 1.5.
No, we were going to stick with the 1.5.
Oh, I'm
and then
sorry.
The second dose is just half of whatever your first dose was.
Oh, I'm sorry, I
So
missed
even
that
though
part.
it's the math is still technically the same. If you calculated the first dose, it's half of whatever your first dose was.
So this would be an addition. So where our current protocol says amiodarone 300 may repeat 1 dose of 150, you would add under that or lidocaine
Yes.
1.5 milligrams per kilogram. I'm sorry, is there a max on that? No, for a single dose. Right, but there's no max.
Yeah, it's the total dose cannot exceed 3 mg per kg. So if we by doing 1.5 and 7.5, we would not exceed the 3 mg per kg.
Okay.
And it,
1.5 and 7.5 to the official dose.
So if the PEDS is going to be 1 milligram, would it not just be easier for memorization purposes to just have an adult that has 1 milligram per kilogram as well, since that is also within the guidelines?
0.5. All right. So then to make it easier, the recommendation will be 1 mg per kg, second dose, 0.5 mg per kg on the adult and the pediatric protocols, never to exceed 3 mg per kg for national standard.
Okay. I may pull you up to read this off during my report for MAP. Okay. That's awesome. Okay, is there a second to that proposal?
So I will second the 1 mg per kg, repeat 0.5 mg per kg, not to exceed 3 mg per kg total dosing for both the adult and pediatric cardiac arrest protocols as the alternate to amiodarone dosing.
And I'm sorry, just really quick. Apologize. Just for briefness purposes, if we're gonna say first dose 1 mg per kg, second dose 0.5 mg per kg, there's no reason to say not to exceed 3 mg per kg, right? Because there's no way in the protocol for you to go that high. You're only giving 2 doses and 1 mg and then 0.5. So there's no reason to put, just to make things briefer. Sorry.
Perfect. Yep.
So I apologize. Now you have to modify
it makes more
your
sense. And
you
then
have to modify your motion. Sorry.
so
Yeah, let's restate it for me just one more time.
in the addition to the antiarrhythmic box or lidocaine 1 mg per kg IVIO may repeat every at 5 to 10 minutes at 0.5 mg per kg.
May repeat one time.
Yeah, one time, right? At 5 to 10 minutes.
So
Only say one time, say.
Yeah, no, at 5 to 10 minutes.
Humans everything.
yeah.
Yeah, no, we're removing that. We're removing that.
Okay.
Correct.
Yeah, we're changing the.
Just like amio is 1 dose and second dose, so lidocaine can also be 1 dose, second dose.
Okay, so lidocaine, 1.0 mg per kg IVIO bolus may repeat at 5 to 10 minutes, 0.5 mg per kg.
Yep, one time.
Okay.
Sorry. Was there is it still in the HA guidelines, or there was in the past? But when there's conversion and that's the antidysrhythmic that's used, was there therapeutic levels that had to be maintained, or is that no longer in the guidelines?
Are you talking about if there was ROSC?
Yeah, ROSC. Yes, thank you.
Um, No, looking into this, I
No, what we don't,
Okay.
yeah.
Okay.
We can talk, yeah.
Right. So just to keep it as our current box, right, says amiodarone 300 milligrams IVIO may repeat 1 dose of 150 milligrams if refractory after a 5th shock. So then you would also, then the similarity to that language would be, or lidocaine 1 milligram per kilogram IVIO semicolon may repeat 1 dose of 0.5 milligrams per kilogram if refractory after 5th shock, just to keep it consistent with the amio.
Yep, that works with me to keep it consistent. I think there's another topic here about AHA saying that, I know that, again, none of these medications show a whole lot of benefit, and I do agree that lidocaine is moving us in the right. Like, we're in a protocol that we're leveraging small percentages to move big mountains, but there's also this topic of, the sooner that these antiarrhythmics are in, the better they work. And I think that we're handcuffing ourselves to saying 3 shocks and 5 shocks. I think that there's a topic of that as well. here, right? I'm not asking for it to be the first line drug, right? Because just topic, I don't think that there's anything. But if we're talking about the third and fifth shock, I think that we're already 10 minutes, 15 minutes into a response time before things are established. And that's how we get to IOs and why probably AMIO doesn't show a lot of termination in the field. But I think that also, since we're maybe on this topic, can we remove the third and fifth shock of this? Because I think that that is handcuffing these entities so aggressively that these antiarrhythmics are getting pushed back into the 16, 18-minute marks, and they just don't have effect at that point. That if they are in a shockable arrhythmia, the sooner that we can provide these therapies, I think that that's giving them the best chance. Yes, I know that that chance is low, but I think that that's giving it its best chance. Just early, right? Let it be. Yeah, because that's what it says in the guidelines. That's why the 5 to 10 minutes is in the guidelines. It's not a third or fifth shock. It's just early.
Yeah.
Once you have IV established, right? Again, kind of the conversation is that we should. I don't necessarily agree with it, but I think that it's a bigger conversation to say, I don't think epi has a place in shockable arrhythmias, right? But to me, right, and the way that we would practice this, right, is that IV gets established and we're in a shockable arrhythmia, the antiarrhythmic is the first one that should be administered. It has its highest effects if it's given within the 8 to 13 minute mark. And then all we're just asking is remove the third and fifth shock. These protocols don't have to be a step by step. We can put it into the provider's hands to use, their education that they got brought up with of, hey, this stuff works better if it is given early, and then recognize your timing of these drugs of 5 to 10 minutes.
I'm definitely okay with removing the criteria of shock numbers, because I agree. I think that is a little bit odd way to do it. But all of the guidelines do say that these medications are only indicated for shock rhythms that are refractory to defibrillation attempts, right? So obviously always your first treatment is defibrillation.
Yeah, and I'm not saying that we should forego that. I'm saying that it's just in the front end of it, to your point, right? Compressions, ventilations, defibrillation, the things that we know is effective, right? But once an IV is established, I think removing the third and fifth shock requirements and just saying 5 to 10 minutes, right, within that time frame, I think gives, again, the providers more success to do it early and give these medications the best chance.
Okay. Yeah, I mean, again, I go back to the Rock Alps trial, right? Even placebo had a better efficacy given early on in cardiac arrest, right? Where I think the take home message from that is the earlier you treat cardiac arrest with compressions and appropriate defibrillation, the better the outcome. No, I understand that, and I agree.
They may have a better shot, and so
Right.
that's all we're asking.
And so, right, and I understand that. I'm just trying to see how you want to change the current protocol. Honestly, then if the protocol is open, then you could change the amiodarone box as well to remove the refractory after fifth shock thing, right?
And that's what we're asking for, is that like the epinephrine box just says, once you have an IV established, it's every 3 to 5 minutes, right? And I think that once you get an IV, the recommendation should be amiodarone 300 repeated at 150, and remove the third and fifth shock, and then the lidocaine, just putting the timing in it, because we already have the timing example for the epinephrine. Like, we don't put it every single box for 2 minutes. We just say within 3 to 5 minutes, we just copy the standard from AHA. And I think that would probably be ideal, is like, once you have an IV, first dose of lidocaine at 1 mg per kg, repeat after 5 to 10 minutes at a half dose. And that puts it into the provider's hands to just say that once you have an IV established, you are managing your medication's timings, and we're not locking their hands to third, fifth shock.
In that case, just remove the 5 to 10 minute restriction as well, right? Just say may repeat may repeat one dose of 150 milligrams.
Perfect. Yeah,
Or we could look at, like, a lot of our medics treat cardiac arrests as a pattern, right? Like they know every 2 minutes pulse check, every 2 minutes, they've got to get that epi in. What if it's, as you get the IV in, amio or lidocaine first dose, and then after your third shock should be about that time frame, as long as it's refractory, refit, BTAC. And then that puts our providers in that pattern state of, now I know I have to give my second dose, which would be somewhere between the 5 to 10 minutes that you're proposing. The caveat to that, I didn't think about this until I started speaking, which is very common for me, is if it's not refractory VFib BTAC, if it goes in and out, that could throw that off. So I don't know, just throwing out a suggestion.
yeah, and the AHA, just doesn't provide any guidance. Like you could technically give the 300 and then the very next rhythm check, you could give the 150 per their standards, right? So I think that just saying may repeat, right, if still refractory is kind of covers all of our bases. It's just saying that once the IV is established, a 300 amio or a 1 mg per kg lidocaine may repeat if still refractory at these dosages. Yeah, and
And even if you come out of it.
and that covers the basis of if still refractory, consider an additional dose of 150 or the 0.5 mg per kg.
Okay, so I think where we are now is we're going to remove the Q5 to 10 minutes and out of the lidocaine box, and in the amiodarone box, we're going to remove the specification of shocks, waiting for shocks. We're going to replace that with may repeat if refractory.
Yes.
Okay. And so just make sure I understand it. So where we are now is we have a proposal to add lidocaine to the cardiac arrest protocol with 1.0 and then a repeat of 0.5, may repeat if refractory. What's that?
One or continuous?
Times 1.
Times 1. May repeat times 1. Okay. So, and that's the current proposal?
Yep.
Terrific. Is there a second for that proposal?
Peds.
Oh,
It'd be the same.
Yes,
Repeat.
Mirrored language.
yes.
Second.
Okay. All in favor, say aye.
Aye.
All opposed? Okay, so that carries. Terrific. And I know with the permission of Henderson, we were going to move the ketamine discussion down a little bit and try to work our way on to just, I appreciate that too. Thank you. I know. Hopefully we'll get there. Discussion of the chest pain, ACS, and STEMI protocols. Dr. Holtz.
All right. Hopefully this is a relatively non-controversial change. No, sorry. Trying to be hopeful here. Essentially this would hopefully simplify the chest pain, non-traumatic chest pain and suspected ACS/STEMI protocol. The current protocol, there was some concern that the nitroglycerin box information is a little confusing, which I agree with. So this is hopefully to kind of amend that. It also, the current protocol also is a little bit, odd in how it separates non-diagnostic 12 lead to STEMI. And this would just kind of combine all of these, combine the STEMI protocol with non-traumatic chest pain into one thing. So, as you can see there, it goes from 12 lead EKG within 5 minutes patient contact. If it demonstrates STEMI, immediate notification to the intended receiving facility, aspirin, vascular access. Oxygen, this change also changes the SpO2 guidelines to only give oxygen if pulse ox is less than 90. And that brings us in line with the most recent guidelines on ACS. And then nitro, you can see the changes there. There's some adjustments for the nitroglycerin contraindications in the pearls. And then the rest of the protocol remains the same in terms of antiemetic medications and so on.
Discussion?
So the only thing that we have that we would need to change is the general adult assessment has oxygen for patients under 94%.
I'm sorry?
General adult assessment is one of our protocols and it says oxygen for all patients under 94. I understand where you're coming from as
Yeah.
far as the standards.
No, I understand what
but
you're saying. Yeah,
that
because
would
that
mean-
would, this would be separate for this protocol only. Yeah, you're right.
Right. It's also
Um,
something that we look at for the protocol exam.
Sure,
It's an all or nothing thing since it's under that general protocol.
right. Yeah, no, I
So
didn't think about that. That's a very
really-
good point. I'm not sure the best way to square that circle in terms of making that change. Hmm. Yeah, I don't know. If anyone has any other thoughts on that, that would be a separate discussion, I think, about changing that. That's, general assessment protocol. But again, this, the
Structurally.
90% is the more
protocol,
recent guidelines for
It's meeting.
ACS.
But it hasn't been agendized.
It's not on the agenda.
Okay.
These
If we,
protocols won't roll out until July at the earliest.
no, I know. I mean, so if we were to approve this, can we then
Bring it back in April.
agendize the discussion of what to do with the O2 sat for the next meeting?
Sure.
Okay. Yeah, go ahead.
One of the other things I guess I would like to see personally is the order flipped between pain management and nitroglycerin. I'm a much bigger fan of using pain management as a first line for patients with acute chest pain as opposed to nitro as my first. And I think that the way a lot of our providers read this is like straight down. And I don't know about anybody else in the ER. Is nitro your first thing or is pain medication your first thing for patients for acute
Yeah,
chest pain?
to be perfectly honest, I wholeheartedly agree.
So
I
I would
don't
love
even
to
use
see
nitro
that
anymore.
flipped. And then I would like to have language about consider nitroglycerin because there's obviously situations in which they should not be giving that. And the way it looks right now, it's very prescriptive that nitro is an expectation of treatment in patients with acute chest pain. So my recommendation would be to flip pain management ahead of nitro and just put consider nitroglycerin. And then I also think that we need to have provision for holding aspirin in suspected aortic dissection. We talk about it under the pearls for nitro, but I also don't want, if a provider is suspicious of aortic dissection as a cause of non-traumatic chest pain, to not be giving aspirin ideally in those patients.
I wholeheartedly agree with flipping pain management above nitroglycerin and making nitroglycerin a consider medication. To be honest, I would be fine with removing nitro altogether. Just as we all know, there's no mortality benefit to nitro, and it does affect hemodynamics much more significantly than fentanyl would. That being said, it is still in the AHA guidelines for ACS, which is the only reason I left it in, to be honest. And it's also it is also elsewhere in our protocol manual for pulmonary edema. So yeah, I completely agree with that. The aspirin component, that may be a bigger discussion as well, just because aspirin is the one thing that we know does actually affect patient-centered outcomes for ACS, and it is the most important medication to give early. There's also DAVP. Yeah, exactly.
It was
Well,
just a consideration to hold it if your suspicion. Yeah.
That may be an
But, yeah,
education piece.
Okay, so perhaps we can hold off on the aspirin thing for the moment. I mean, another option that would be to just simply say aspirin 24 unless contraindicated, and then mention that that's a
Totally fine with
contraindication. So we're now branching off into a couple of different things. So let me try to figure out, does anybody disagree with the idea of moving pain management above nitroglycerin? No.
Putting the fentanyl preferred language in there since we don't have preferred anything in any other protocol. I understand where you're coming from, but we don't have that language.
Maybe we should look.
It's fair.
Make a difference. Maybe that's something we can add in any other.
Right,
Hemodynamically,
like, we typically add it in pearls. That's where that language is seen.
Okay.
Yeah, either way, I'm fine. If you want to add a pearl to say, fentanyl is the preferred, pain medication in non-traumatic chest pain, that would be fine with me, to be honest. My only point was to, make it known, stress that fentanyl is the least hemodynamically effective pain medication that we have available. Otherwise I agree with moving pain management of nitroglycerin and making nitroglycerin a consider nitroglycerin medication.
Okay, so where are we right now?
Okay.
So unless there's any further discussion, I think that we're at moving pain management above nitroglycerin, making nitroglycerin consider, and removing the fentanyl preferred from the first page and adding a separate Pearl to say fentanyl is the preferred pain management or pain medication in non-traumatic chest pain.
We just add the Pearl then for the aspirin. So like consider holding aspirin for suspected aortic dissection. Just make that a Pearl and be done with it.
Yeah.
Yeah, that's
And then we
fine.
can just close that.
Now, is everybody okay with changing nitro to a consider?
Yes.
Okay. Okay, so what we have on the table right now is we're going to move pain management above nitro. We're going to make nitro a consider. We're going to move the fentanyl preferred in pain management to pearls. And then we're going to add a pearl for,
Aspirin for suspected aortic dissection.
yeah.
Just because I know that there's nothing else in the protocols that addresses aortic dissection and
Okay. Okay, and so that's the proposal that's on the floor. Is there a second to that? Okay, all in favor, say aye.
Aye.
Opposed? Okay, so that carries. That takes us to the, and Mike, we'll just pull both of these up at the same time because I believe these are mirror images of each other, the pediatric and then the adult respiratory distress protocol. Or are they different?
Kind of. They're pretty separate, to be honest.
Okay, which one do you want to do first? Do you want to do adult or peds?
Take your pick. I'm good either way.
Okay, well, peds is up first, so let's do peds.
All right. So, spent a lot of times, going through our respiratory distress protocols. I think our current protocols are not the best in terms of aggressiveness of dosing of medications and how they spell out, various other treatments. So I was trying to address those deficiencies by amending these protocols. I think the easiest way to do that is to split it up into 3 separate protocols. As you can see, I split it up into a PEDS respiratory wheezing and bronchospasm, a separate one for Stridor group and upper airway issues, and then a separate one for foreign body airway aspiration or foreign body airway obstruction. So starting at the front, wheezing and bronchospasm. I know it looks a little bit busy, but when you kind of look at it a little bit, it isn't all that difficult, I don't think. It basically splits it up into a mild wheezing, mild respiratory distress, in which case you just give them a single dose of albuterol ipratropium or Duneb, reassess, see if they're back to the normal state. If they're not, then you can get shunted over into the more moderate or severe respiratory distress. That pathway starts with, for patients in extremis, you can give IM epinephrine. If they're not in extremis, then it has more aggressive dosing for albuterol ipratropium. Also points out, giving fluid resuscitation if dehydrated, also adds magnesium as a medication for pediatric wheezing. And then also adds non-invasive positive pressure ventilation. And I know that this would be a change for our non-invasive positive pressure ventilation protocol, as that is currently restricted to above 18. So this would have to remove that. And I don't believe that was added to the agenda, unfortunately. But we can amend that next time. And I understand, that not everyone's going to have pediatric masks. So that's why I said if appropriate size mask is available. I think that this would be a less common intervention in this patient population, but I think it's an important one to have available. And many pediatric patients, may fit into our smaller adult masks if you don't have a PEDS mask available. But I just wanted to have that as an option. Otherwise, pearls have been updated slightly, and QI metrics were added. And then for the Stridor group upper airway, you can see it just it will consider other things like allergens, anaphylaxis, in which case it puts you over into the allergic reaction protocol, or foreign body goes into the FBAO protocol. And then it just basically says, is there epiglottitis or is concern for epiglottitis or not? If there is, then the suggestion is to minimize agitation and transport, right? That being said, in the pearls, you'll note that epiglottitis is less common in peds now, thanks to vaccination for Haemophilus influenza. So I think that's going to be a less common thing. And then obviously, if there's no concern for epiglottitis, concern for croup, treat with nebulized epinephrine. And again, UI metrics were added to that protocol as well. And then for the foreign body airway protocol, this should all be relatively familiar to everybody. This just updates it with the most recent AHA guidelines for pediatric foreign body airway. But it also specifically lays out that direct laryngoscopy is an option for paramedics, and also cricothyroidotomy. The only thing that I need to add to this protocol that was not in this draft, and I apologize, is the radio symbol for the consider cricothyroidotomy in pediatrics, as that is a standard in our system. The only other thing that is a little bit different that you may notice is the consider slat technique. I found that in a few other protocols that as I was looking through this around the nation. It's not something that I'd heard before, to be honest, but it is intriguing as an option. And difficult to find some evidence on this, to be honest. I'm okay with leaving it in or taking it out, depending on what people want to do. But essentially, it's SLAT is simultaneous laryngoscopy and abdominal thrusts, where if you're doing direct laryngoscopy, you can see a foreign body, just below the vocal cords, but you can't reach it to grab it out. The thought is that if you do abdominal thrust, it pushes that out of the vocal cords, allows you to grab it and remove the foreign body. So again, I'm okay one way or the other if people want to leave that in or not. And then this also has QI metrics. So I know it's a lot to take in. Hopefully everyone's reviewed this before today. And any comments?
Mike, why don't, because there's a bunch of different elements there. Why don't you kind of direct us, pick what?
All right, let's start with, that's fine. Let's start with the wheezing and bronchospasm protocol. Hopefully this is the least controversial of these. Again, I think the biggest thing is this makes our dosing of albuterol, hypertropium, and adds magnesium. So it makes, more aggressive treatment for pediatric wheezing and bronchospasm.
Discussion.
I have a question. Why was Epi 1-to-1 initially taken out of our protocols?
I'm sorry?
So Epi 1-to-1 was initially taken out of our protocols. We used to have it many years ago. It no longer is. Now it's coming back. Why was it taken out in the first place?
That is a historical question I don't know the answer to. Dr. Young? Yeah.
It all looks good. Yes, all of it looks good. Yep, we're all for it. I don't think there's anything else to be discussed on this. Just it's a national standard to do IM epi, right? The fact magnesium isn't there right now is beyond thing. And if you have the ability to do non-invasive positive pressure, you have BiPAP or a small enough peds, like there's nothing wrong with it. I think we can get to the piece of like removing the 18 or older and just letting it reflect, if indicated.
Yeah, my goal was to just remove the 18 or over restriction from that protocol. It's like strike that 2 words basically in that protocol.
So I think we're all good on this one, Mr. Chairman. Yes, all around.
Yep, I'm good here on that one as well.
I'd like to, go ahead.
Just to add to the QI metrics, I think that it's an important point that all of these patients in respiratory distress should have active end-tidal CO2 monitoring. And so that just continues to be a basic expectation that end-tidal CO2 should always be present on any respiratory distress patient. So.
Okay, and then I just wanted to make sure, so how does that work from a mandatory equipment standpoint where we have the masks if available?
I'm sorry, the what?
Does that affect so do we mandate that people will carry pediatric masks?
No, and that's why I was saying if, make it so it's if available. I don't think that would be a mandatory equipment standard. Sorry.
I got one question, Doc. We had a patient the other day. It was an adult patient, respiratory distress, MAG would have worked perfectly, difficult to get in an IV.
Right.
Now that we give MAG for eclampsia IM, is there any movement or is there any way we could consider IM or a larger dose of magnesium IM on respiratory distress, either with adults or pediatrics?
To be honest, I'm not.
I haven't researched it, so
I'm not familiar. To be honest, I'm not familiar with IM being a common thing for respiratory distress patients. It's more of it's a secondary medication. I think the most important medications are the bronchodilators, and IM epi if needed, right? So to be honest, would be in favor of just leaving it as it is and not adding IM as an option, just to avoid irritating your respiratory distress patient more with a big slug of IM medication. Yeah. Does it? Yeah. Yeah, eclampsia is more for seizing patients and yeah, right.
So since this protocol goes over what basic, advanced and paramedic, maybe we should just modify the end title just for advanced providers that have end title available. They should be using it for trending. That should be a QI metrics on all three. If we just make a blanket statement, it should be on all three. Yeah. And the issue with the mask and proper fitting masks and agencies, we'll discuss that in QI.
Yeah, I think that can be for discussion. At least right now, I wanted to get it on the protocols to have it as an option.
It sounds like there's consensus that everyone is okay with the wheezing and bronchospasm portion of this. Do we want to? What do you think would be next?
Can I? Yeah. Do you want to take these individually or?
Well, that's the thing is that if there's not going to be any heartburn, we could do them as a group, but we can also do them individually. Either one's fine.
I just bring up one thing. We have ipratropium listed as an AEMT capable drug.
Yes, that was the other change. So I want to change that. To be honest, it boggles my mind. I'm not sure why it is a paramedic only medication currently. That makes no sense to me. So that's why it's a change here to an AEMT drug.
Okay.
Generally speaking, when we add a new medication, which we did with ipratropium, it is a paramedic only drug until we get our feet under ourselves. And then we can move it elsewhere. Same thing with Zofran and stuff like that. We started as a paramedic, smaller cohort, easier to control, check what the problems are. If there are any, and correct them, and then move them down the line as necessary. So that's why it's there.
So
We just never moved
have
it.
we
just never moved it.
Have we had it long enough that we can move it out now?
Oh yeah, it's been years.
Okay. Okay.
Just like but that's the problem. Like the inertia, like it stays there. So
You're the brain trust. You tell me what to do. So you don't tell me what to do, I'll go.
all right. So does anyone have any issues with just moving on to Strider Group? Does anyone have any issues with? So we can hopefully take these all at once. Any heartburn with the Strider Group upper airway protocol?
Humidified air oxygen, you know what I mean?
So I took that out specifically because there's no evidence for it. I think that's what's our current protocol, right? Is humidified.
Yeah. Stop saline. And just do saline, like nebulized saline.
For
Maybe doesn't need epi. You know what I mean? It's like
well, for which
proof that
where on the protocol would you put that?
above the nebulized epinephrine, the patient's not. You know what I mean?
I mean,
Giving nebulized epi to everybody with croup, with moderate to severe. I mean, if you're no, you know what I mean? Do you even just use the nebulized saline? Just up at the top where that just
right.
continues.
Yeah, if they don't meet the moderate to severe respiratory stress. To be honest, I do not see the benefit of, humidified or nebulized saline in these patients. Dr. Horning, Dr. Horning's here, sorry. If anyone has any thoughts on that, but to be honest, I am in favor of leaving it out.
And those patients are getting nothing. Essentially. For a parent that called 911 because their kid wasn't breathing well.
Dr. Horning, you should be able to unmute if you'd like to speak on this.
Thank you. there is no data to suggest that nebulized saline makes any difference. And it's not used very much anymore. And under the wheezing protocol, epi 1 to 1,000, now epi is 1 milligram to 1 ml. And then for the 1 to 1,000, I don't know if we should put that dosing on there as well as the 1 to 1,000.
Dr. Horning, I apologize. I missed about the last 5 to 10 seconds about what you said, but I did catch the first part of it. And like I said, and I'll point out that I did discuss a lot of this with Dr. Horning as I was making these protocols. We did remove that.
We'll defer to her judgment as the pediatric ER provider, like.
And Mike, I don't know, do we need to revisit the dosing?
Of what?
Uh,
Sorry, what was the comment on that? I apologize. I missed that.
The epi now comes as 1 milligram per 1 ml. So when you get the cartridges, that's what's on the box. I don't know if we should put 1 to 1,000 and as well as 1 milligram to 1 ml, because you're going to see both.
Oh, I see. So yeah, just after epinephrine 1 to 1,000, just a little parenthetical 1 milligram per ml, basically. Sure. I mean, that's fine. I mean, you're essentially saying the same thing, but it just makes it more clear. That's totally fine.
Okay, and then so are we down to a foreign body?
And then foreign body. Like I said, this just brings us in line with the most recent guidelines for peds. Again, we're going to 5 back blows alternating with 5 abdominal thrusts, or except for infants where it's back blows and chest thrusts. And then just needs to add the radio to the cricothyroidotomy box. And then again, does anyone have any thoughts or comments on the SLAT technique thing? I'm okay in or out on that one. No strong feelings one way or the other. We could take it out and just make it an educational component. Whatever anyone wants to do on that one. Not a recognized thing. Yeah. No, it's interesting. I agree. It's not a standard or recognized thing. It's more of a, hey, this is something that could be tried. So I'm fine with removing it and just making it something that could be educational item.
It's in the pearls.
It's in the pearls. So that's what I'm saying. But I would remove it from if we're going to remove it from the front, I would remove it from the pearls as well, probably. That's what anyone has, Or just leave it. You want to leave it in the pearls, you're saying?
Scary calls,
Sure.
give people the education, like we were talking about, since they are.
Sure.
Give them a little bit more education of, hey, man, I'm struggling.
This is an option. Sure. Okay. In that case, yeah, the only thing for that, the only amendment to this item would be consider SLAT technique from the front page, from the flow sheet option. We'll leave it in the pearls.
So it looks like we're at the point of where the proposal could be made to adopt these changes, the pathway with the addition of the 1 milligram to 1 ml dose, the epinephrine box on the wheezing bronchospasm portion, and the removal of consider SLAT technique in the front page of the foreign body protocol. Is that correct?
Correct. We would also add the 1 milligram per ml to the nebulized epinephrine, because that's also 1 to 1,000. So after 1 to 1,000, add a parentheses 1 milligram per ml, and then add the radio icon to the cricothyroidotomy box on the FBAO protocol. So
said add pedal CO2 monitoring to the QI metrics for all of those protocols.
Yep. So with those amendments, I will make a motion to approve all 3 of these pediatric protocols.
Is there a second?
Second.
Oh, I apologize. Can I?
Yeah, go ahead.
Actually, no, that's it. Sorry. Thank you. I was like, okay, wait a second. Hold
All
on.
right, second for second time.
Can I ask a question really quick? This patient unresponsive says begin CPR starting with compressions. It is very likely the way that most of us practice that if they're going to show up to a patient in cardiac arrest, an eye gel is going to go down first. Right. And
But
I don't necessarily agree with that practice. I think that we should be assessing the airways for foreign bodies, especially in children. But is there value into it just adding into the pediatric cardiac arrest? There's already a pearls box is to consider foreign body obstruction early on in the arrest model, because it is very common the way that this city practices that if they show up to anybody unresponsive without a pulse and the CPR is being done, they will throw an eye gel down and the most junior person will ventilate this patient over the obstruction.
So for this protocol specifically, patient unresponsive, this is not a patient unresponsive without a pulse. This is patient unresponsive with a pulse. You're talking about, so you're talking about changing the.
Yeah, just adding a little, like there's already a section that has like transport ROSC after 20 minutes, pit crew approach, right? Is that there's a very likelihood that again, that may not be discerniated, right? If they're considering these things, is there value in adding just into the cardiac arrest one? I'm not saying that we shouldn't approve this, right?
So we would have to go back to the pediatric cardiac arrest protocol, which have to be agendized again, unfortunately.
Yeah, we can do that, but
it's going to be a different protocol
on for next time.
Yeah,
which is a good idea. So we should look at that.
For cardiac arrest protocol, non-traumatic is open because it was part of the first set of protocols.
You're correct. We could go back to it. But for now, can we stick to these three and then make that adjustment? Just to make some forward progress.
Let's do these, say that we're going to add it on to the pediatric cardiac arrest before we move to adults, so we don't forget to go back and add it.
Tell me exactly what we're adding to pizza
Okay.
cardiac arrest.
Well, hang on. Let's Let's do these.
These three first.
Yeah, so let's finish up with the pediatric respiratory. Is there any more discussion on pediatric respiratory? Okay, so I believe that we have the proposal with all of the changes that we made, and there was a second. Is that where we are?
Yes, sir.
Great. All in favor of adoption, say aye.
Aye.
All opposed? Okay, great. Okay, now we're going back to, this was, item D. Okay, and so what's the proposal there?
There's already a Pearl box that says like transport with ROSC 20 minutes, pit crew approach 9% in survival, like that. Just adding a bullet point to consider foreign body early in arrest, right? To make sure that we're not jamming eye gels over these patients prior to assessing the airway in its entirety, especially in pediatric patients, right? Like adult patients, I get it, right? We can absolutely have the indication that more likely it's going to be a cardiac event or some other type of medical episode, but in children, just considering that foreign body is a more likely opportunity for us to arrive to somebody in cardiac arrest or to a heart rate less than 60, that we should be weary of foreign body early in this thing. And we should not be throwing eye gels in these patients before we assess the airway in its entirety.
Okay, so can I summarize that? So
Yes.
under the PEDS cardiac arrest pearls, there's the first one is respiratory failure. Right underneath that, consider foreign body airway obstruction as a cause of cardiac arrest and assess airway prior to any other airway interventions.
Perfect.
Can you repeat that one more time, please?
Maybe.
Yeah, maybe.
Consider foreign body airway obstruction as a cause of cardiac arrest and assess airway prior to other airway interventions.
Yeah. Beyond BVM ventilation.
Can I what if we just simplify that to put in that box under above transport with ROSC after 20 minutes, just say, consider foreign body airway obstruction and just make it easy.
I'm okay with that, absolutely, because then it's on the entities to.
And to be honest, we could also add this to our differential diagnosis box, right? Which are still going to be in the protocols.
And I think it has value up there, because to the point of this committee is that the providers look at these on the way to it. They don't necessarily look at the pearls on the way to this. And that little box up there would give that value of just saying like, hey, this is a common thing. Before you jam an eye gel or, make other moves with it, be okay just considering foreign body obstruction.
How about we just make the little A box under so the epinephrine, and then it says consider extraglottic airway device, assess airway prior to placement of or foreign body obstruction.
Yeah.
Wait a second. Where are you?
Foreign body obstruction.
The front part of the protocol
So
under
Dr.
consider
Morgan,
extraglottic airway.
that protocol was not approved. Or that's not the current
This is the
protocol.
pediatric non-traumatic protocol.
We just amended the current protocol with adding lidocaine. That is a very separate and distinct protocol. It's not the one that you're looking at.
Okay, so what's on the table right now, Mike?
So
When you had read
my recommendation would be to adding to the current protocol, which I don't know if Dr. Young can pull it up. There's a box at the top right with transport with ROSC, pick through approach, 9% decrease in survival. I would just add the first item there would just be consider foreign body airway obstruction or consider FBAO.
Okay. So that's our proposal right now. Is there more discussion?
If you want to do that, but again, sure, yeah.
Well, I think a consider is,
Yeah.
consider foreign body in that situation is reasonable. Is there a second to that proposal? Great. All in favor, say aye. All opposed? Okay. And Mike, I'm probably gonna have to come back to you and MAB to explain this stuff. 'Cause I'm starting to drown. Okay, and then so that ends the discussion of the pediatric respiratory distress protocol. So let's move on to discussion of adult respiratory distress protocol.
Awesome. All right. So very similar to the pediatrics, this was split into respiratory distress and then foreign body airway obstruction. There's no Stryder, there's no separate one for Stryder. The Stryder, there's a arm on the flow sheet under respiratory distress here. It is, as you see it, it's also hopefully should be relatively uncontroversial. The only change that I'd like to make to the draft that you have in front of you, the dosing for albuterol, it says 5 to 10 milligrams SVN. I would adjust that to 2.5 milligrams to 10 milligrams. Just to allow us to give, and then also for the ipratropium, I'd change that to 0.5 to 1.5 milligrams. That would be the only change that I would advise here. Otherwise, it should be relatively similar. Ipratropium goes to be an AEMT medication. Non-invasive positive pressure ventilation is on there. Pearls have been updated.
Sat,
And I'm sorry,
you sat.
what do I have on O2 here? Oh yeah, I apologize. We need to change that to 94% just to keep it in line with our current protocols. And then for the IM epinephrine, which was also added, you'll see that it's very specific that it should only be given to patients with a known history of asthma and extremis. That's why it's kind of its own little box there, just because it should not be used in COPD routinely.
We had entitle CO2 to the UI metric box.
It's already on there. Well, it's already on the flow sheet
Um,
under the paramedic cardiac monitor capnography 12 EKG. Sure. And then the FBAO protocol, again, just correlates with current recommendations. And again, I would say let's remove consider slat technique from the front flow sheet, leave it in the pearls. That's about it.
Thank you for adding QI metrics.
Of course.
Discussion?
Dr. Holtz, I missed that first drug dosage change. I got the ipratropium. What was the other?
Oh
one?
yeah, sorry. For albuterol, the dosing should be 2.5 to 10, not 5 to 10.
Gotcha.
And ipratropium should be 0.5 to 1.5.
Dr. Holtz, well thought out. I make a motion.
Covered both, correct? The respiratory distress and the foreign body airway obstruction?
Yep.
And then again, we'd also change put a parenthetical after epinephrine 1 to 1,000 parentheses 1 milligram per ml. Okay, sounds good. If there's no further discussion, I'll make a motion to approve these two protocols with those amendments.
All in favor, say aye. All opposed? Okay, so that passes.
Did you say that the consider slat technique was gone? I
Yes.
missed that. Okay.
Yes.
On that one. Cool. Just checking.
Okay, and then, so moving on to discussion of pediatric behavioral emergencies protocol.
All right, so this just came from a discussion of our EMS committee where the newly approved pediatric behavioral protocol, and I'm sorry, I don't have the draft in front of me. We added droperidol at a dosing range of 0.1 to 0.3 milligrams per kilogram with a max of 5 milligrams. The goal there is again to, kind of allow a range. But there's been some discussion that it may be easier and more beneficial for our paramedics to have a set dose for droperidol, just for ease of memorization, to avoid having that range there that's be memorized. And so I discussed this with Dr. Horning. We just, came up with just, go cut it right down the middle, 0.2 milligrams per kilogram would be a good happy medium. So I'd like to propose that change. If there's any discussion.
Discussion?
Correct. And it would have the same max of 5 milligrams. IV or IM.
Are you waiting for a motion?
No, any further discussion?
Yeah. Not from my end, no. I think these are, in my view, these are pretty well-established therapeutic doses. I think the QTC risk has been if it is there to be at much higher doses, I'll defer to Dr. Horney if she's still on the line. But again, I think these are pretty well-established dosing guidelines and appropriate for IV or IM. Okay, and Mike, can you give me that dosage again?
So it would just change the 0.1 to 0.3 milligrams per kilogram and just change that to 0.2 as a set dose. Again, so 0.2 milligrams per kilogram IV/IM, max 5 milligrams.
If you need a draft of that protocol, it's actually in your handouts under the droperidol stuff.
Okay.
Thank you. That's where it was. Yeah.
I'm just a little. We took that in adults. I have no.
Dr. Horning said she's still waiting on the.
She's online.
Okay.
Hello, yes, I agree that these doses are well thought out and minimize risk for prolonged QTC, and this would be good.
Additional discussion? Oh, we have the proposal. Do we have a second?
A second.
Okay. All in favor, say aye.
Aye.
All opposed? Okay, so we're adopting that. We have 20 seconds left for discussion. Okay.
All right. I hope this one maybe doesn't add so much controversy. We spoke on it previously at the last meeting very quickly. My ask of this was two things. We're underdosing the Versed. We're at 7.5. I'm asking to change that to 2 doses of 5. Is that we actually get up the national standards for 10 milligrams for the adult portion of this. Refractory seizures to benzodiazepine therapy happens in 40% of these events. So almost half of the people that we will give this to, we've arrived too late in the seizure for the benzodiazepine to be effective. I know that there are better anti-seizure medications that have in the ER, but for something that is cost neutral that we already carry with us, we have a We have a therapy where there are studies that are done in EMS are showing 95% termination of seizures that are refractory to the benzodiazepine therapy. I think that it is safe. We already have them on end-tidal oxygen therapy, and providers are already ready to do ECG monitoring and to bag patients by giving benzodiazepine therapy. So we already have those things in play. What I'm asking for is to add a dose of ketamine if you have run your Versed treatment. If you've given 2 doses of 5 milligrams, and they do not terminate the seizure, to add what I have here is just from a different system. I looked at systems that were doing this. This is from Palm Beach, Florida, where Dr. Antebi advises. This is his fire department. He has them give a 100 milligram of ketamine and 50 milliliters of normal saline to drip it in to prevent the respiratory stopping from the ketamine. So he has them drip it in over a period of time to terminate the seizure. And all that is that all these other pathways that in the GABA complex that Versed works on are stunted after a period of time. They're believing that happens after about 15 minutes of the seizure. All the ketamine pathways are still available. So through a different mechanism, it is terminating the seizure. And I think we have it. It's safe. We already have the practice of ECG monitoring, SpO2 and end-tidal CO2. Yeah, adding it as an option. And I'm open to discussion on the dosaging. This would just, I looked for fire departments and EMS systems that already do this, saw what they were doing. And this is just a really well-established one that had this recommendation.
Discussion?
I'll just follow up. I think that this certainly could be find a place on the rigs. I did just for the benefit of the group and other parts of the discussion, you said our neurology, our stroke neurologists, our ED pharmacists, they kind of responded saying that couldn't support it. The department's using better to carry. But I think there is a role for it. I would say, see the cost a little bit, just because the receiving facilities that are getting these folks, if they're neurologists, this might be a bit of the needle spectrum. But there's also education that we can put out and say, hey, this might be an option for us. And it beats a seasoned patient, if you don't have any options. Some of the transport times can be longer. In other systems that have studied this, we typically don't tend to have that problem as much, but we can. There are some times when we will have long transport times. So I would say if we do want to go forward with it, obviously we would need to QI it carefully, and I would actually support doing a request for medical orders for this. Obviously would defer to the will of the group, but I don't want patients to show up to the ERs and then have the treatment team and the ER be surprised by giving a medication that they're not typically used to giving for seizures. I think it's better with a notification. To notify the derm that you're doing it, or you can also, we can say, request for orders to give it if the patient is still actively seizing. So I bring that up for discussion with the group. Your thoughts on saying, should we do it as medical control, or should we wait until there's more data out for it?
I just say that I have a hard time sometimes waiting for medical control because depending on who answers the radio, there's a lot of people unfamiliar with protocols, and we've seen that in termination or resuscitation and all the other things. And so I have a little hesitancy unless they're actually getting an EMS trained physician or one of us sitting in this room who are knowledgeable.
Lots of variability, but there's also lots of variability where you can.
And I'm being informed that I am over time. So, what?
I think we have until 11, actually, don't we?
No,
No?
we're already in
We're gonna do
MAB.
MAB.
We only have a half hour for MAB.
Ah,
Okay, Kat, super quick.
Yeah, people saw, just a quick point. There's a couple of recent things on MRAP and on other studies where there's concern that their patient is still seizing. They're just not actively moving from the ketamine. And we don't have anybody here who does continuous EEG monitoring to see if they still are actively seizing, even though their body's not moving. And that's kind of the problem we have with propofol as well. There's also concern for losing that secondary neurological exam for an extended period of time when you're using the higher doses of ketamine. So unless we have really good buy-in from our neuro people behind, I don't know that we need to be pushing this. I mean, I like the idea, but I don't think it's quite ready for prime time unless we have a lot of support from our neuro colleagues that are going to be picking them up on the back end.
Thank you. Okay, like I said, really full agenda. Okay, so I don't think there are any board reports. Okay, terrific. So let's go to second public comment.
Nothing
That's not
online.
public comment. Okay, nobody else. Okay, great. Is there a motion to adjourn?
Motion.
Okay, then we surrender. We are adjourned.
I'm gonna let them see you smoke.
Well, I'm gonna need help.
That was.